You, Onkar, for the introduction. I heard Onkar saying when the debate started, we are going to discuss and debate ischemic heart disease, PET versus MR. He completely forgot about CT. So I just want to ask the audience before I start the presentation. So my presentation is CT FFR the way forward for hemodynamically significant stenosis. So I just want to know what you guys think. How many of you think it is the way forward? CT FFR, is it the way forward for hemodynamically significant coronary artery stenosis? Okay, can you put the presentation? It's coming. Okay. So the overview of the presentation is I'm just going to talk about what a hemodynamically significant stenosis is for CT, and then what are the limitations in using CT coronary angiography. How does CT-FFR works? We look at a bit of review of literature. I don't want to go into detail because Tarun has done a wonderful presentation 2 days back. Few cases from my institute, and then debate whether is it the way forward. So what is hemodynamically significant stenosis means? So any lesion that is causing ischemia, so that lesion is hemodynamically significant. It is important to know this because myocardial blood flow can be improved either by medical therapy or revascularization, and doing this correctly reduces the risk of major adverse cardiovascular events. So CT coronary angiogram is the most widely used technique. It is a fantastic technique to rule out. So that is why it has a strong recommendation to be used as an investigation for chest pain. That is class 1, that is the strongest recommendation. And level A, that means it has the highest evidence to be used as well. But the problem with CT is that it is good to say that, okay, there is lesion or there is no lesion. But once you say there is a lesion or a stenosis, you cannot say whether it is hemodynamically significant or not. It has very poor positive predictive value for hemodynamically significant stenosis. So that means that there is widespread implementation of CT, and that can lead to unnecessary invasive coronary angiography because of its high false positive rate. If there is 50% or more stenosis, there is a chance that most of these patients go for further functional testing. So where does the buck stop? So if we want to know whether the patient needs to go for OMT or revascularization, for revascularization, we need to know the anatomical information. So CT is fantastic, so is ICA, but it is invasive. But we also need the functional information. We need to know whether it is hemodynamically significant stenosis or not. To know that, there are techniques like stress CMR, stress echo, nuclear medicine, but they do not give anatomical information. So how do we marry these two? So we can do CT coronary angiogram and do CT myocardial perfusion. We had a fantastic talk by Dr. Kakuya the other day. So the drawbacks of it is that you need a modern scanner, dual source CT, and it is technically quite challenging. It can increase the radiation dose as well. So the alternative, we can think of invasive, we all know about invasive coronary angiogram FFR, but there is also CT FFR as well. So is CT FFR the one-stop solution then? Because it's giving anatomical information, giving us the functional information. And unlike ICA, it is non-invasive. So we have an interventional cardiologist with us chairing the session, so I won't go into detail of ICA. So it is considered a gold standard investigation to look for hemodynamically significant stenosis. And it is measured during invasive catheter angiography by using a pressure guide wire, placing it beyond a stenotic lesion, and measuring the mean distal coronary pressure to mean aortic pressure under maximum hyperemia by giving adenosine. So it accounts for collateral flow and myocardial demand, and hence it is a better predictor of outcomes after revascularization. CT-FFR, on the other hand, is a physiologic simulation technique, and we use routine CT coronary angiography data to mathematically model coronary flow, pressure, and resistance. And the only technique that is available to be used and that is FDA approved is the HeartFlow, which uses computational fluid dynamics with off-site supercomputers. So this is how a workflow of CT-FFR is done. So CT coronary angiogram, a good quality CT coronary angiogram, if acquired, a 3D anatomical model is segmented from it. And then they use a physiological model based on input and output hemodynamics. They also consider the resting myocardial blood flow, which is proportional to the myocardial mass, and also that the microvascular resistance is inversely proportional to the size of the epicardial arteries. So, so there is no injection of adenosine because even that dynamics is taken care of. And all this data is then sent into supercomputers which, for heart flow in California. And they use this complex computational fluid dynamics equations. And then we get a color-coded 3D map of FFR-CT. So when you look at the color-coded 3D map, you can see that it varies from red to yellowish, red to yellow, then to green and blue, and it is I don't know if you can see. Yeah, so the scale is between 0 to 1, and if there is a total occlusion, it is modeled as an X. And you can also see, if you observe carefully, that there are some gray areas that are seen. So the gray is for vessels that are less than 1.8 millimeters, so which the CT-FFR does not account for. So on the top, you can see all the coronary arteries that is being mentioned, and any FFR-CT value which is less than 0.75, it is considered abnormal. That means there is presence of ischemia. Anything more than 0.8 is considered normal, that there is no evidence of ischemia. Anything between 0.76 to 0.8 is considered borderline. So between invasive FFR and CT-FFR, apart from invasive FFR being invasive, we need to understand that invasive FFR is available only where it is measured at one single point. But on CT-FFR, it is quite interactive. So you can place your cursor anywhere and get the values. However, just like in invasive FFR, where it is measured immediately less than 2 centimeter distal to a stenotic lesion, it is recommended that in CT-FFR we do the same as well. So do we require to do FFR-CT then on everybody? Most of us know that coronary stenosis is categorized as low, intermediate, or high risk category. Low risk anatomy, if there is stenosis less than 30%, usually optimal medical therapy is recommended. For high risk anatomy, for high grade left anterior descending artery stenosis, or if there is a significant left main stenosis, if there is 3 vessel stenosis, then most of the time coronary revascularization is recommended. For occlusive lesions, again, CT-FFR is not done, it is not validated. However, if there are stenosis in other coronary arteries, then we can look at CT-FFR in these coronary arteries. So who may need CT-FFR? So it is this intermediate risk category which falls between 40 to 90% that may benefit from an FFR-CT. So if the FFR-CT is less than 0.75, then coronary revascularization may be preferred. And if it is more than 0.8, then maybe these patients may be given an optimal medical therapy. But if it is borderline, then we need to look at various patient-related factors to understand what is the best way forward. So how does CT-FFR compare with CT coronary angiogram? So there are multiple studies which have said that the accuracy and specificity is quite good for CT-FFR compared to coronary CT angiogram. And when we look at comparison between CT-FFR and invasive FFR, there have been multiple studies from 2015, and you can see there are multi-center trials, single-center trials, and also meta-analysis, which have compared CT-FFR with invasive FFR with good accuracy, hovering between 70 to 87, and very good sensitivity as well, ranging between 80 to 90%. Somewhat moderate specificity, moderate positive predictive value as well, very good negative predictive value. This is across all the studies. So how does CT-FFR compare with others? So FFR-CT has higher sensitivity than both SPECT and PECT, higher accuracy than PET and SPECT on per vessel basis, and comparable accuracy to CT perfusion technique. So this is the reason that it has been included in CADRAT's 2.0 document as a modifier I If there is presence of ischemia, it is I plus. If not, it is I minus. If it is borderline, it is I plus or minus. And also the reason why NICE guideline recommends using FFR CT, and it may avoid the need for invasive coronary angiogram and revascularization and perhaps save some costs. So let's look at three cases. All three cases came to us from Rapid Access Chest Pain Clinic. So this is the first patient who had a moderate stenosis in the proximal LAD. And if you look at this color-coded CT-FFR map, so if you look in the distal region, obviously it looks like there is ischemia, but as we discussed, we need to look at it just distal to the lesion. And if you look at it at the just distal to the lesion, it is 0.8. So then there is no clear evidence of ischemia in this case. So another patient who had diffusely diseased proximal to mid LAD with moderate disease in mid LAD. And again, if you see distal to the lesion, it is quite low, 0.73. So this patient, there is evidence of ischemia. Case 3, again, mild to moderate stenosis in the proximal LAD. And if you look at the color-coded map, you can see that distal to the lesion, it's all blue. So there is no evidence of ischemia. And occasionally in the distal vessels, we do see this, that it is quite low, but it is not significant. So does the buck stop at CT-FFR then? Because you don't need to do any additional imaging apart from what you've already acquired. So there is no reason to give additional radiation as well. And it identifies hemodynamically significant stenosis in the intermediate group. Is it a one-stop solution? So far it looks, yeah, good. Looks like it. Then we had Tarun discussing this in quite detail, so I won't go too much into detail. But this publication was published recently in JAC in 2023, August. And it looked at 2,298 patients who had CT coronary angiogram and FFR CT. And the most common symptom in all these patients, with 77% having stable chest pain. And 40% of those patients only had moderate coronary artery stenosis, moderate coronary artery disease. So that means that 60% of the FFR CT that were sent did not have moderate coronary artery disease. And the positive predictive value in this study in UK was 49%. That's like tossing a coin. And if you look at the cost, by using FFR CT, the cost increased per patient to 2,100 pounds. If you add 2 zeros, that's your number in Indian rupees. And the other thing that we need to remember is that it's not like when you do the CT and then you immediately get the result. You need to send it, and then it takes up to 3 hours for you to get results. So it's not like you're going to get an immediate result. The other limitation is also that in all of these conditions, it is not validated. If there is a stent, you can't use CT-FFR. But you can obviously look at the other coronary arteries. If there is extensive calcification, then again it is not validated much. So then if you now in research, like there are multiple publications that say, oh wow, CT-FFR is fantastic. And in 2023, we have this publication which says, no, it is not. And that it is coming from a country where it is made as a guideline, and now we are thinking what to do. So we have to also understand that there are other options to heart flow as well. One is Siemens. So I don't want to go into detail, but this is from United CT Imaging from China, this paper, and they have an on-site CT-FFR that they're trying into, and it has good sensitivity, specificity when we compare it to invasive coronary angiogram. And they use some alternate boundary technique to get the CT-FFR values. So there is also something called a smart FFR, where it looks into the endothelial shear pressure to give you a color-coded map. So this is like Brexit. You know, in 2016, UK had a referendum, and then there was like 51% who voted to go for Brexit. It's like Britain exited from UK. So in UK, if you talk to most cardiologists or radiologists, this is the debate. Most of them are highly favoring FFR, and you have another group which says no. So is it like a Frexit? I just coined this term. There's no such term. So is CT-FFR the way forward? If you ask this question to me today, I cannot definitely say yes, because the research is such that it is swinging both ways. And the cost, in an Indian scenario, 70,000 rupees, maybe patient will get treated, will have an entire treatment, then just get one investigation perhaps. So it's a huge cost. So going forward, I do think yes, because we do have the technology and we need more hands-on and on-site solutions. And we need to move away from one monopoly. We need to like have perhaps indigenous techniques, look into all of this, and as radiologists or cardiologists, we need to study it. And we need to know how the measurements are done and what the values it is throwing up. Thank you.
That's an excellent presentation. It's good to know that there are options for non-invasive FFR testing, and maybe I said it has a lot of room for further development. And from the surgical aspect, I think maybe in multivessel disease, when the non-LAD tertiary is not very significant, and if the FFR is less, then we can go for a minimally invasive access to revascularize the LAD alone. So I think there are few subset of patients which might benefit. Thank you.
Thank you.
Any questions?
Bhavana, one question and one comment. In the 3D color models, when you say proximal LAD had a lesion, you have to measure 2 centimeter distal to it. But the distal LAD, which shows the red color, where there is no disease, what does that signify?
So this is something that we see in most, not most, I could say few patients, where suddenly in the distal LAD there is some. So it means to us that there is ischemia, but on CT coronary angiogram we cannot see a lesion. Whether it is microvascular obstruction, we don't know what is the cause. But at that lesion, that particular lesion, is not causing significant stenosis, but what is happening is distally something that we go back and we check to make sure that there is no lesion proximal to it. If there is no lesion, then either it is technical or there is some ischemia that is perhaps something at a microvascular level.
Because what I worry about is in an area where there is no stenosis, you've got a low FFR value suggesting ischemia. Now, if there was a 40% lesion, and again you had FFR values which were low, we are going to falsely call them as positive in that case.
In distal?
In distal,
Okay.
Because the distal third of the LAD.
Yeah. But we don't put it at all in the report as well. Only if it is immediately distal to the lesion, we say anything. But
No.
anything distal to it, we just put in the comment may represent some ischemia. But even on literature, it says as the vessel diameter reduces, then you can't like make any treatment plans based on what we see.
So, to save money, do you only send proximal lesions then?
So this is a very good question, because there was a sea of change that happened from last year to this year. So last year, almost all coronary artery stenosis which were moderate were being sent. And I think after this paper, if I could say, some 60% cardiologists were sending cases like that. Now we are pushing them back and asking, because what used to happen is even then, we need to understand that this is being funded by some innovative program in NHS. So the NHS is paying £700 per patient when we send these cases, right? So when we did that, we also realized that, okay, the cardiologists are asking us to do CT-FFR. We are telling them, okay, there is ischemia or no ischemia. Even on patients where we have said ischemia, then they triage them again. So they don't take them for revascularization. So then we went back and said, please triage them. Just send those patients which you're sure if we say something that you're going to take. So that was one part. Then this publication came. So then we had a big discussion. So now the point is, should we continue to use it or not? So we decided, let's audit. Let's sit back and audit, because until now we were not doing invasive FFR. We have not done it at all. So we don't know. So we need to know our own practice, check and be very clear on what we are doing, whether it is right or wrong. So in 1 year, I think there'll be more data, and I think most centers in UK are going that way.
So, Hemant, just one comment. For the knowledge of everyone, there are newer softwares called, one of them is called QFR,
Okay.
which is basically exactly equivalent to CT-FFR, but in cath.
Okay.
So you just do a diagnostic catheter angiography,
Okay.
and it gives you
Gives-
FFR of
yeah.
every vessel at every level, without having to go in with
And put
a
the wire.
guide wire or that. And that is also very, very effective
Yes.
as of now.
Thank you.
A lesion where the values suggest that it's ischemia, okay, my say 0.75, and if I do a stress test on him or stress thallium, and there is no ischemia, how does the cardiologist look at that lesion?
They will look at the stress test, not on CTFM. Because this question, there would have been a different answer last year to now. Now I think people are questioning, because even Tarun showed, if I did send that, if I have sent that case with so much of calcium, I don't know how they have calibrated it. So it is difficult to be, very sure that the value that what we are getting is 100% accurate. It is good. This is my experience has been, it is very good when the quality of images is fantastic. But anything moderate quality or there is lot of calcium, it is a question. Yeah. Yes, yes. So on literature, it is 2 to 33%. So in 2 to 33%, this is in literature. In my practice, it used to be like every month. So we used to do 150 cases, and we used to send, I think, 15 per month. So in that 15, at least 2 would get rejected.
Okay.
Thank you.
Thank you. Thank you, Bhavana. Though it was a debate, you were very honest in your talk. I would request Dr. Gunasilan to felicitate Bhavana.